Thank you. So I want to speak to mental health because that's my area of interest. And I'd like to first thank Indiana University for the support that they've given us as the mental health department since I joined Moi Teaching in Referral Hospital in 2013. I've actually been involved in work since 2016 specifically, that was funded by Indiana University. And what is the work that we are doing? So the first thing for us to understand the background is that mental health in Kenya has always taken a back seat. And for the longest time, the priorities, understandably so, have been HIV and diseases that cause mortality. But unfortunately, we also know that there are very many people who continue to struggle with mental illness. And because of the lack of priorities in terms of human resource allocation, the budgeting allocation, these people continue to suffer without help in terms of mental illness, whether it's depression or substance use or anxiety. And it's because the society where we live in especially also doesn't understand that this is illness. For the most time, as long as you don't have fever or your pressure is not high, then it is assumed that you're well. Of course, unless you burn a house or you attempt suicide, and then that's the only time people realize that it's serious. So the problem that has been is a huge treatment gap for mental illness and the limited resources for the same. And the work that we have been doing is an attempt to increase access to care. And what have we been doing in this regard? It is several-fold. One, we understand that the society itself generally does not understand what mental illness is. So one of the things that we've been trying to do is increase community education. And this we do from addressing large gatherings, whether it's in church or school, or we also target specific key leaders like village elders, the chiefs. We have talked to the school teachers, especially the ones who are involved in career guidance, because they're the ones who see children. And most recently, we've also been involved in talking to people like the police officers. So that's the first thing that we've been trying to do, increase education. The second other important thing is the issue of capacity building. So there has been a gross shortage of psychiatrists and psychiatric nurses within the country. As we talk, for the 40 million plus Kenyans, there are less than 150 psychiatrists in the country and slightly more than 500 psychiatric nurses. Those are not enough to take care of everyone in Western Kenya or in Kenya who really need help. So one of the things that we have been doing, and we've been leveraging on the gains by AMPATH, the care they have been giving for HIV and diabetes. And so what we've been doing is trying to build capacity for the clinical officers and nurses who are in the primary care settings, who are taking care of other illnesses. And our conviction is that if you can take care of a patient with diabetes, if you can deliver a mother as a nurse or as a clinical officer, then you would be able to recognize depression and initiate care. So what we have been doing is to increase capacity through training. Initially, we used to do large group trainings, and we train, say, 30 clinical officers in a room. But most recently, we've realized that that does not work as well, because sometimes people want to be trained for different reasons. Some want to get a certificate, some want to be trained because it's also an opportunity to get out of the hospital and change from usual routine. So one of the things that we've realized most recently is, instead of doing capacity building in large groups, is we also identify what we call champions. And these champions is a clinical officer who we have trained, but we also work specifically with them to build their interest and to continue supporting them to initiate care within a primary care setting. And we are proud to say that we have about 8 clinics within Western Kenya where we have established a clinical officer and a nurse who is interested. Of course, not everywhere we can say that it's very successful. We are still working on that, but at least we are able to receive calls from this clinical officer. And every time you receive that call, you know that at least they are seeing a mental ill patient. So capacity building is the second thing that we are doing. The other important thing that we established is that while it is great to screen people, as we have been doing, we've been doing screening initially using community health volunteers. We've done screening for mental illness using the general healthcare workers and trying to link them, but it's not always very, very easy to do that. So the one thing that we have been trying to do is to also work with the county so that they're interested in this mental health care. Because one of the things that we've learned is that people for the longest time believed that everything else was important. So we've also, in addition to working with the primary care workers, is also working with the leadership. So we actually do presentations to like county health management teams and try to have their buy-in in terms of mental illness. And that has been continuous. So we are doing capacity building, we are screening, we are sensitizing the leadership to be interested. But the other important thing that we try to do, especially for alcohol, is that we know that like in Western Kenya, there's only one rehabilitation center the government owned, and it's very expensive. It would cost at least 90,000 Kenya shillings minimum in the country to access care for the 3 months that's required. And actually, so that cost has gone up in the recent days. And many people cannot afford that. Yet, the people who require care are those who can't afford. So what we do, one of the things that we've done is instead of waiting for them to come to the rehabilitation center, which they will never come, or even travel 100 kilometers or more to come to Moi Teaching and Referral Hospital, is to establish alcohol support groups within the community. So what we would do is that we would screen for mental illness. We usually would screen for depressions, alcohol use, psychosis, and anxiety. But for the alcohol support group, for the alcohol and support, the alcohol users, we know that they won't come to the rehab, or they won't even go to the healthcare center, like for depression. So one of the things we've done is to bring them together within the community. Initially, we use community health volunteers, but most recently we are using peers. So the peers would bring them together. It's like an alcoholic anonymous group where you bring them together. They have conversation about their alcohol use, and they encourage each other to stop taking alcohol. And we've been following up. We have a calendar that we try to map whether they are reducing their alcohol use in terms of drinking days and the drinks that they're using per day. And one of the things that we have had, of course, we have not done this in form of a clear research. Actually, this is a time where we are doing some qualitative interviews with these group members to see how it has helped them. Of course, we wish we did it as a study from the word, because mostly this was care. But from the stories that you hear from individuals, many lives have been impacted, and we've managed to record a number of stories of people who would not stop drinking. They could never come to the rehab, but their lives have changed. So the alcohol support group is the other thing that we have managed to bring people together, and we believe that is bridging the gap for those who cannot come to the rehab. What would be the areas of priority? I still believe that there's a lot of stigma for mental illness, even right now, despite the work we are doing of community education and of bringing people together and educating all these groups. There's still a lot of lack of awareness and stigma. And so for me, an area of interest would be ways to increase awareness of mental health and mental wellness and stigma reduction, so that people can be open to seek care. Because as much as you do capacity building, as much as you, even if you are to increase human resource for mental health, if you don't take care of the stigma, if you don't increase awareness, then seeking care may not be optimal. Of course, we also want to continue capacity building to ensure that we have more people who are competent to provide care. And the other important thing would be strengthening the referral system, because we have seen that, okay, we have people who are on the ground who are willing to provide mental health care, but sometimes it is not very well structured where the patient is referred to, are they referred to. If Kwobah as a person who has interest is not available, and the patient is seen very, very fast. And the other area, of course, of interest is strengthening supplies for mental health care. What we've noted is that, unfortunately, for the longest time, the county governments around had never stopped drugs for mental health care. And so it's been a struggle. Initially, we tried to support even the clinics to try and sort of start them, but it's taken a long time for them to be interested in stocking drugs, even the basic ones for mental health. So that's what I'd like to say. Thank you. Back to you.